Hello, my name is Chad Curry. I'm the training chief at UMCMS, and welcome to one of our CE sessions talking about PAI intubations. Sometimes we start thinking about the PAI process and the long road that it may endure in order to us to make good decisions in order to get the patient safely intubated. And so today we would like to talk about that process of PAI. So today, as we talk about some of the objectives we'd like to cover today, we want to talk about sizing up our patients and getting a great patient assessment, talking about the oxygenation and ventilation of these patients, and that can give us clues to if we need to stick with the BLS side of oxygenating and ventilating, or if we need to move to a more advanced side, an ALS side, with the PAI intubation. We also today want to gain a deeper understanding of the medications that we use for sedation, for paralyzation, and for post-intubation sedation. We also today would like to look at learning about the importance of the organized approach into intubation, the monitors part that we need to complete our process of PAI, and we want to talk about the pre-intubation interventions that we need to make sure that we have a good stepped process in order to have a successful intubation. Finally, we'd like to review some videos of direct and indirect intubations and learn about the techniques that hopefully will improve our process for first-time intubation success. As we dive into the PAI process, we want to begin the process by making good, sound decisions. Nothing that we do in the field, in the pre-hospital setting, is without consequences at some point. Whether it be an IV could cause an infection later on, a wrong drug, and especially when we start talking about taking somebody's airway from a PAI standpoint. The thing is, we've got to remember is that we're betting that patient's life on our intubation. Oxygenate and ventilate them doesn't always mean that we need to intubate them. And sometimes this is one of the hardest decisions that we can make as an ALS provider. We just need to make sure that we're making a good judgment call in the field in order to have a great outcome for our patients. Sometimes even for the most veteran paramedic or ALS provider, when we start thinking about the PAI process, a lot of times we start with that container ship that's going into the large storm. And sometimes it just feels like this is going to be a very difficult process that we have to get through as ALS providers. One of the biggest things is we can, in order to head into this storm, is to make sure that we have preparation and they're always having our backup plan ready to go, and that we have plenty of help coming our way. So there's three major questions that we want to really address to ourselves as PAI providers as we start to make this decision in order to intubate these people. So one of the first questions we like to ask ourselves is, what is the reason why I need to PAI this patient? Is the patient putting me into a position or forcing me into a position to where the risk of me taking their airway outweighs or equals the benefit that I'm going to get from the intubation? Just because I have the ability to oxygenate and ventilate somebody doesn't always necessarily mean that we need to intubate them. And so this is one of the very first questions is the patient forcing me into a position where I can't do anything else? I can't oxygenate them. I can't ventilate them. Or I'm able to do that, but I can't keep an airway clear. And so I'm being put into a position where I have to take that airway. The next major question I come to when I ask myself about PAIing somebody is, do I have a backup plan? What is my backup plan? What is my partner's backup plan? And we've talked about our plan. Always be prepared. We think we're sizing these patients up, or it should be a fairly easy intubation, but you never know what lies inside until you actually get in there and take a look. Always make sure that you've thought about it beforehand. Okay, I'm going to have my bougie ready. I'm going to have my emergency airway, whatever blind insertion airway device you choose to use, whether it be a King or an LMA, or even back in the combi tube days, we had multiple devices these days, and as we go further along in our medical careers, we have a lot more advanced blind airway insertion devices to pick from. One of the things I want to ask myself is, can I immediately oxygenate and ventilate this patient if I have a failed airway attempt? So am I able to go back to the basics in order to supply the patient oxygenation and ventilation while I'm getting prepared for my next step? Third questions that we address as ALS providers is the PAI in the best interest of the patient? And I say that, we feel like it may be the best interest for our purposes to secure an airway, to make it easier to manage that patient in the field. But is it long term going to be beneficial for that patient? Are they going to be able to come off the vent? Do we have other options that are available, such as basic airway procedures, oxygenation, ventilation, using some type of an adjunct airway, maybe an NPA? Positioning that patient, possibly even using CPAP if their level of consciousness is high enough, and or just going back to the basics of a BVM. So it's just one of those other questions that we need to address to ourselves before we PAI the patient. As we continue to look at these processes of making good decisions in the field, so we're buying off on when we finally need to make that decision to intubate. Which of these patients are more likely to need intubation instead of BLS management? Well, one of the biggest things we think of usually is head injuries. These patients may be too obtunded in order to control their own airway. We worry about aspiration at that point. Severe combativeness from the head injury itself. That may be a very just cause for us to protect not only ourselves, but to protect that patient at the end of the day from injuring themselves further. Clenching or jaw unresponsiveness. If they're clenching, I'm unable to suction them if they do vomit while I'm trying to use a BVM, then that's definitely going to be a big problem. And something else we don't always think of is facial injuries. What is the compliancy of the BVM and the face mask? Am I able to get a good seal? Am I able to ventilate them? And that goes back to that question of, can I oxygenate them and can I ventilate them? Which the answer at that point would be no. We talk about our burn patients, inhalation injuries. We have to be very aggressive if we see soot, if we see any hoarseness, wheezing, we hear those things. We need to make sure that we're aggressive in securing that airway quickly. Prolonged seizure activity. This is something that we fortunately don't have to do a lot of with all the benzos that we have on the truck. We have a lot of different options with that. But there are selected times that we do have to intubate those seizure type patients that are continuous seizures. Just remember that this does require medical direction approval, so you'll need to call on the radio and get approval to go ahead and PAI, and maybe they may have another option of giving another drug. Other conditions that deem that the paramedic determines that intubation is indicated but would not be possible without paralyzation or sedation. So we try to leave that open for you guys because there's not always a situation we can explain, and so you have to be able to make those decisions as best judgment as you can. And then if it wasn't the right decision at the end of the day, we can always go back and re-educate, re-talk about those things. But for the most part, the paramedic's going to be able to make those decisions properly due to their education. As we begin, and you're walking out to the truck with the patient, or you're bringing supplies into the house, wherever it may need to be done, you really start to size up that patient. What does their neck look like? Do they have a small chin? Can I get them into a position where I can work with them? And these are things that we have to start sizing our patients up and looking at the situation and where we are. How difficult is this intubation going to be? Do I have any neck and facial trauma that may hinder me being able to A, ventilate them, B, oxygenate them, and or get them into a position to where I can get them intubated. Remember that cervical collar is going to restrict some of that airway positioning, and so that's one of those things that I have to be able to address, whether I have to go to manual stabilization, do an inline intubation. We always worry about blood and emesis. We can't always roll those patients. Sometimes they may be too big. They just not be able to be rolled, or that emesis and blood may happen once I get them paralyzed and I have a blade stuck in the throat, and so I have to be able to address those issues quickly. One of the biggest things we talk about is our positioning, and that's getting first of all, you into a position where I have a zero angle where I can look straight down. One of the things we like to talk about is getting to the ear to the sternal notch and making sure that we have a good alignment there. With our pediatric population, we may have to pad underneath the torso of the body in order to get that child into more of a neutral position due to the size of the head on our kids. A lot of our population that needs PAI in the field a lot of times may be obese patients, morbidly obese patients. This is a even stronger factor, is something that we have to deal with, very hard to deal with a lot of times. They're not able to get into a position that we can work with them. B, they have a lot of pressure on the vena cava from just their natural body weight laying flat, so I may need to move them to a supported or a semi-Fowler's position. Maybe if I could get their head a little further back and drop it back just a little bit, as long as there's not a neck injury, that's always a great option. And that may be just to ventilate. I haven't even moved into the PAI process yet. That's just to go back to the basics of ventilation, because that's one of the things we need to talk about. Can I ventilate them? Because if I can, eventually I'm going to move from I'm not in a PAI standpoint any longer. I'm in a cardiac arrest standpoint, and I need to get that airway quickly. As we start to talk about ramping the patient or placing things behind them, as you can see in the demonstrations to the right, laying somebody flat is going to be a very, very difficult intubation versus once I get them kind of propped up. I could use the cot to do that and actually pull them up like the picture to the left, to where I have the head kind of more hanging off. May put it into a position that I may be able to work with a little bit easier. So one of the further and the harder concepts is that we talk about is, especially for some of the older paramedics, is we've always lived off of that kind of that scoop and run mentality, to where we've loaded the patient quickly, moved to the ambulance, got him out to the hospital. When we've moved to more of a systematic approach of taking care of somebody more long term and stabilizing those patients on scene. The patient's airway can both, one of those things we have to ask ourselves, can the patient's airway safely and adequately be managed with is this something that I can do without risk of aspiration? Able to go back to the BLS portion and ventilate and oxygenate these, or do I need to stay on scene, and do I need to intubate these people? At the end of the day, sometimes it can be a lot safer for us to bring the bags into the residence and do everything inside versus maybe possibly sometimes moving to the truck, stabilizing that airway before the hospital, or just using an NPA or OPA, simple BVM, and able to ventilate without risk of aspiration and transport into the hospital. So what's my backup plan? That can't be answered enough. Has me and my partner talked about this? Am I working with somebody that I don't usually work with? What is their backup plan? What is my plan? I want to make sure that I have my rescue airway option. What is that? Is it a good option for this patient? Can they tolerate that? Is the increased pressure inside the throat they're going to be able to tolerate, or do they have carotid disease? And so I have to worry about those things. Can I physically get into a position to intubate these people? Am I in a small bathroom? Do I need to get them out to where I can work, till I can get on the ground and take a good look? Do I have someone that can get into a position if I can't for some reason? Always think in your head, how will I manage this patient's airway if I can't secure it with an endotracheal tube? What are my options? Do I have a bougie option? Can I go back to BLS procedures? Do I have a blind airway device, or do I need to move into a crike? One of those processes is why our partner goes and gets the PAI drugs, or maybe while I'm getting the truck set up. One of those things I need to think about is to have everything in order. Make sure that my IV's patent. Make sure it's going to be able to flush good. I'm going to be able to get my drugs on board in order to put everything into my advantage. Do I have enough experienced personnel there? Should I call for a Fox truck? Should I call for an extra ambulance? Maybe it might be me and a younger crew, and I'm a young medic, and that's one of those things that unfortunately in today's world that happens. We wish we could put everybody with a more experienced person all the time, but that's not always the case. And so we want to make sure that we have a good experienced personnel there, or at least have them coming. So if we're not able to get the tube, we can go back to BLS management, and we can get that patient intubated successfully in a timely manner. We want to agree on the patient's weight. We want to talk about those things. Patients under the age of 10 or under about 80 pounds, we want to make sure we're using our Broslow tape in order to be successful at this. So now we've successfully made the decision that it's time to intubate, and I'm starting to get everything prepared. PAI intubation can be safe. It's proven that we've done it very successfully with a 93% success rate. But it's one of those things that we want to make sure that we have everything prepared beforehand. We're organized with our system, that everybody's talking, everybody's visiting. We have our drug calculations, and everything's set up and ready to go, and everybody remains calm through this process. For the actual PAI process, once again, we start to use our BVM. We have our airway adjuncts out and ready to go. Our OPAs, our MPAs, we want to watch our rate and our chest rise. We want to make sure that we're not over-ventilating that patient, adding too much pressure to the chest and putting pressure on the vena cava, which is going to cut down preload, which will cut down the afterload, and that's going to cause us some problems that we've created. We want to get that patient positioned. We want to elevate the head or the torso on our pediatric patients. We may have to ramp that patient. We may have to, like we talked about before, move them up on the cot and kind of get their head hanging off just a little bit in a more of a relaxed state. We want to start our passive oxygenation with a nasal cannula at 8 to 10 liters per minute. Place those in the nares and make sure that we can use that with a BVM. And we want to make sure that we get those reserves full of oxygen before we start this process. So we've got our suction ready to go. Everything is prepared. I have Yonker ready. Everything's connected. I do have positive power, whether it be on the portable suction or the truck. You know, that cap is not pushed down all the way. It's not going to work. So I need to double check that everything's ready. Have my heart monitor ready. Go ahead and have my capnography out, plugged in, ready to go. That way I can get it on quickly to confirm, especially if I've got a patient that's maybe a CHF patient or a dialysis patient. They may already be full of fluid, and so that fluid may come up the ET tube quickly and ruin the capnography sensor. So I want to make sure that I get that on quickly in order to get an initial end-tidal CO2. Remember, end-tidal CO2 is the gold standard across the United States for confirmation that I have waveform, capnography, and numeric value. I'm going to get all my PAI medications ready to go, label my syringes with silk tape, make sure that I have the right drugs available. Remember, our respiratories require ketamine instead of etomidate because of the beta effect from the ketamine that we want to help with the bronchodilation. I want to make sure that I have confirmed that the drug, I've showed my partner the drug, that I have the proper amount, the expiration, and that we're ready to go. We've made decisions as a team that everybody's in the same understanding that we are going to use these drugs for this situation. I want to draw up the amount that we need. That'll help prevent from overdosing the patient. So make sure that we're drawing up just what that patient weight warrants. So as we start to move to the drug selection process, we want to start at the very beginning, and in case we do have a head injury or we suspect increased ICP, with whether it be a CVA or a spontaneous bleed that we are suspecting in the field, I want to pre-medicate those patients with lidocaine. Ideally, its administration needs to happen 2 to 3 minutes before the intubation to allow it time to work. Remember, we do not want to use this with bradycardia or second or third degree top blocks on the ECG, because this could increase the hypotension. Why do we not want to use the lidocaine? Well, lidocaine, remember, blocks the cell membranes of the sodium ion channels, and that's going to disrupt that dysfunction. That's going to disrupt that natural potassium and sodium calcium that's going to be cycling through the heart system. And so I want to make sure that that I'm not blocking that and slowing those thresholds down any further than they already are. So how's the lidocaine being beneficial to us? Remember that it blunts a sympathetic response once the blade gets into the throat and touches the larynx. That's where we will have a sympathetic nervous system, the fight or flight, and that's where we're going to start releasing the catecholamines and the adrenalines, the norepinephrines. And so we want to make sure that we're blunting that process, especially if we have a concern of a head injury, because this can increase your MAP up to 35 millimeters of mercury. It could increase it by 35, and also the heart rate can increase sometimes by as great as 30. So we're definitely going to stress that ICP out, increase that ICP even more, which could increase the bleed or increase the pressure on the brain, which is not going to benefit that patient. Next medication of concern that we may be using for the pediatric population is atropine. This will prevent bradycardia, especially with the use of succinylcholine in the field for the pediatric patient during intubation. Children and infants have a tendency to have a more pronounced vagal response from the intubation process, and instead this can cause bradycardia. So this atropine will help buffer that. Although the 2015 AHA standards guidelines did state that there should be some consideration and some thought about using this to prevent bradycardia, but as far as our protocols are concerned, we are still going to continue to use atropine for a pre-drug for PAI process on children. So as we move into our sedative induction agents, moving exactly into the PAI process, we start talking about our drug options of etomidate or ketamine, and we give you guys the choice in order to make that decision of what you would like to use there. We're going to sedate, or we're going to disassociate before chemical paralyzation. One of the biggest things to remember here is that we have to use one of the two, a sedative or a dissociative drug, in order to paralyze that patient. It's inhumane to use a paralytic only. Remember, that patient could be, just think about it, if you were awake and everything was happening and you could hear people speaking and but you couldn't breathe, you couldn't do any more, you couldn't blink, you don't have the ability to tell somebody that you're hurting or your discomfort, and then you're going to have the blade come in your mouth, and that's just inhumane at that point. That ET tube is going to be uncomfortable, and so that's why we have to make sure that we get those sedatives or dissociative drugs on board first. So the first drug we'll talk about is the etomidate use. This is a sedative, and it is a drug that is used as a hypnotic, but it can also enhance the GABA receptors, just like the benzos do during our seizure activity. Remember that the GABA receptors is a potent neurotransmitter that decreases neuron excitability. So this is going to go in there. It's going to increase the GABA receptor, and it's going to start to cause a hypnotic effect and a heavy sedative effect to our patients. Etomidate offers us many advantages as a sedative agent. It has very minimal effect to no effect on lowering the blood pressure, such as benzos would. Like a Versed will lower that blood pressure. It's transit, it's going to come back, but at that time, that CPP, the coronary pressure, cerebral pressure, is going to drop during that time. Etomidate is safe to use with increased ICP. Does not release histamine, so it's very safe to use with patients with reactive airway disease, and it does have a rapid onset. The dose for us is 0.3 milligrams per kilogram to a max of 40 milligrams. The onset is about 15 to 45 seconds, and the duration should last between about 3 and 12 minutes. The disadvantage of etomidate is that it has no analgesic effect, so it has no control over the pain process. When that blade enters the mouth, that's going to be uncomfortable. The tube going through, the tube sitting in there may cause irritation, and etomidate just doesn't offer any analgesic effect. One of the other disadvantages is it may cause some pain in the injection site. At the same time, there may be a brief period of a myoclonic movements that may mimic a seizure that you may see. One dose of etomidate can cause a reversible decrease in the adrenal hormone production, where it decreases the cortisol level. However, current emergency medicine practices still continue to use etomidate, and also they are using corticosteroids at the hospital, or a lot of places are just going to ketamine at this point. As we move in talking about our other option of ketamine, ketamine can also function as a induction agent and replace etomidate. Ketamine works on the NMDA antagonist that, like etomidate, works to inhibit the neurotransmission, except it works on the NMDA side instead of the GABA side. However, this drug usually disassociates instead of sedates. Ketamine also has an agonist or enhancing effect of opioid and beta 2 receptors. That's why we like to use this with our respiratory patients. So it will help decrease the pain, because we use it for pain management also, and for improving bronchodilation. So our dose for this is 2 milligrams per kilogram slow IV push to a max of 500 per dose, and the onset should be about 45 to 60 seconds, so a little bit longer than etomidate, but the duration is going to give us about 10 to 20 minutes for total disassociation. Ketamine, once again, on the dissociative side, puts the patient into sort of an out-of-body or dreamlike experience for that patient. It's not going to actually sedate them to the point where they're completely unresponsive. They still may remain awake, and that's why we're going to use our paralytic at that point, but their mind is not able to associate with that. As with any other medications, please don't assume that these patients cannot hear. That's the last sense to go. And so continue to communicate and reassure your patient that you're taking care of them. With ketamine, we do get some benefit because the patient's respiratory effort and gag reflex stay intact through the PAI process until the paralytic is given. This does give us a little bit of benefit because pre-oxygenation, they're able to breathe, especially if we have our non-rebreather in. And if we're still using a BVM or a face mask, they're able to pre-oxygenate themselves at that point to allow our hands to be a little bit freer if possible. Hemodynamic status, it may actually improve. Ketamine inhibits the uptake of the catecholamines, so norepinephrine, dopamine, and other catecholamines remain fluid for receptor binding. So they're going to actually drive a little bit of pressure. It may have a little increase in heart rate. One of the other things it may do is a little bit of eye shifting and other non-purposeful movements. So sometimes their arms may float up in the air simultaneously. And so that's why a lot of times this drug is not used for shoulder dislocations for obvious reasons. So some of the downside to the ketamine that we have to really pay attention to is if this drug is administered very fast, it can cause apnea and vomiting. So it's something we have to be ready for. We need to watch for these signs. Also, another thing is the blood pressure. We talked about that it inhibits the catecholamine, and so therefore it allows the binding of the norepinephrine, the dopamines in the body. And so therefore the blood pressure and heart rate may go up for a few minutes, and then it'll go back and return to a fairly normal state. If one or both of these arise, assume that the patient, after your sedation period is over and the heart rate or blood pressure begins to go up, realize that that is a time for resedation for these patients. And they may need another dose. They still may have some purposeful movement with that, such as chewing on the tube. Remember, this is a dissociative drug versus a sedative. As we move into the paralytic side, we start with succinylcholine being our front line of paralytic that we use. This is a depolarization neuromuscular blocking agent. It causes a paralyzation of all skeletal muscles. Some of the benefits is it's very short acting in about 30 seconds, and it has a very short duration life of about 6 to 8 minutes. If the airway cannot be secured, it allows that patient to wake back up and breathe again. But there's times that we may need to go ahead and secure that tube because of the patient's status, or they may not begin to breathe again. So our dose for this is 2 milligrams per kilogram fast IV push to a max of 200. The onset is once again 30 seconds, and the duration of this drug would be about 5 to 10 minutes. Succinylcholine works like acetylcholine, which is a neurotransmitter that's needed to initiate cell contraction. So the succinylcholine goes into and binds to the acetylcholine receptor at that point and props it open, if you will. With this ion channel open, it keeps it open and potassium flows out while the sodium ion moves in. This creates a paralyzation stage. The thing is about succinylcholine is it doesn't get absorbed as quickly, and the half-life lasts a lot longer than acetylcholine, so that creates the paralyzation point because those cells are not able to contract. Just like any other drug, succinylcholine does have its disadvantages and contraindications. One of the rare ones is malignant hyperthermia. About the only way to diagnose this is for a family member to tell you that a family member of theirs had fever in the OR and died, and that's kind of one of those big clues that may be malignant hyperthermia. It's a very unique sign at that point, but it's something that we may have to consider. Patient does go into a hypermetabolic state, develops muscle rigidity and hyperthermia at that point, and the hyperthermia side is a very delayed sign of that. One of the other side effects of succinylcholine is hyperkalemia. This will be the increase in the serum potassium levels. Normal serum potassium should be between 3.5 and 5.0 milliequivalents per liter. But succinylcholine can increase that up to 0.55 milliequivalents per liter. And that's it. It's a very small increase that it could cause these patients, but some of our renal patients, some of our burn patients, they can't afford that small amount, and so that's why it needs to be contraindicated with those type patients. One of the effects that succinylcholine may have is if the mature acetylcholine receptors sometimes may be replaced by immature ones. When a large portion of these muscles are not used to paralyzation, they'll cause weakness and injury. This sometimes can last beginning at about 24 hours after and fully convert beyond the 4th and 5th day, lasting months and years sometimes, to have these immature receptors. The problem with the immature receptors is they're more sensitive and easier depolarized. It doesn't take much to open these ion channels in the free-flowing potassium and sodium, and therefore it'll cause that cell to possibly be paralyzed for a long period of times, up to sometimes 4 times longer than a mature cell. So we talk about the hyperkalemia effect, and we talk about who is at risk for this. First of all, our post-burn patients with severe burns, injuries, and are immobile have a risk of having already a high potassium level from the burn sparing the potassium. Therefore, that small increase up to the 0.55 milliequivalents per liter could cause some big problems. Patients that are currently paraplegic, hemiplegic, or quadriplegic could suffer. They already have constant paralyzation, if you will, and so these patients will not do well with succinylcholine due to the extended effect of those. Don't forget also your post-CVA patients that may have some permanent paralyzation there. Also, patients with muscular dystrophy, muscular or multiple sclerosis, Lou Gehrig's disease, a lot of times these can be affected from, they already have permanent dysatrophy from their disease process. Therefore, that's going to cause a long-term effect to those patients, and succinylcholine needs to be avoided with these patients. The dialysis patient, most of these patients live hyperkalemic all the time unless they just came from dialysis. Their kidneys are unable to excrete the potassium, so therefore it doesn't take long for them to build dangerously high levels. A lot of these patients can sit at 6 and 7 sometimes. So any effect on that potassium is not encouraged, and so that is why succinylcholine is contraindicated in our dialysis patients. Vecuronium is our second paralytic that we use. It is a non-depolarizing paralytic that is on our units. Unlike succinylcholine, vecuronium can be used on pretty much any population, given that it does not have an allergy to it. Even with myasthenia gravis, may experience prolonged paralyzation, but is still not a contraindication. Hyperkalemia is not a concern with these patients. Instead of propping the acetylcholine receptor open like succinylcholine does, vecuronium sits in that receptor and without activating it, so it prevents the potassium at that point. So a lot of people may ask, well, with all of these advantages of vecuronium and very few disadvantages of vecuronium besides being a long-term paralytics, why aren't we using that more often? It all comes down to the time. The onset of succinylcholine is going to be quite a bit faster, and for PAI processes, we may be in an emergent airway process, and I need to get those patients intubated quickly. Therefore, I need them to be paralyzed quickly. Sometimes the vecuronium may take over a minute to paralyze completely. The duration of the action is very long. It can sometimes be delayed up to 60 and 70 minutes. The dose of vecuronium is 0.15 milligrams per kilogram IV push, and the onset is usually between about 75 and 90 seconds. And the duration of it is well over 30 minutes and sometimes can last 60 to 70 minutes. As we move in and once we get the patient paralyzed and ready to go, we talk about our equipment selection process. Endotracheal tube size, make sure to use the most appropriate size to prevent from any air leaks that we may have. Have one larger, have one smaller ready to go that your partner can get to accessible very quickly. Our pediatric population, make sure that you're using below about the age of 10 or 80 pounds, that we're using the Brazel tape to get those recommendations. Select the proper blade in preferred style. Everybody has their own style. Some people are Miller, some people are Mac, and some people like to use the King Vision all the time. We recommend that you rotate what you use in order to promote a good process to have all of your tools in your toolbox that you have honed those skills in. On the pediatric side, you may want to use the Brazel tape. It can give you a recommendation of the proper size ET tube and the proper size blade that you may need to use. As I said before, the Brazel tape is very good about recommending the proper size blade, the proper size tube, and helping us guess the weight by how long that patient is. One of the things we can look at, though, is we can kind of size up our blade. If we put the block of the blade at where the central incisor should be, and it should go to about the tip of the angle of the jaw, just below the ear. That would tell me that blade is going to be a proper size for that patient and would be able to get that job accomplished. It'd be just like measuring an OPA, no different with our blade size selection. So one of our biggest obstacles during the actual intubation process, and could be our blade selection process, is our greatest obstacle in the mouth is the tongue. It's very hard to displace. A lot of times the wide curve may help us actually displace that and move it out of the way, versus as the narrow blade of a Miller is just going to actually move and grab everything. And so sometimes the Mac may be more beneficial for us, and sometimes in some points with patients with a very large tongue. Once again, the Macintosh blade is a little bit wider than the Miller standard, and so therefore it will displace the tongue a little bit more easily compared to that narrow blade of the Miller. Remember, once we go in, we're going to the vallicula, and we're going to place the tip of the blade right there into the vallicula and lift. As this moves the epiglottis open, it'll start to lift that epiglottis up and make a good clean view for the vocal cords. The straight Miller blade is once again a lifting tool. It does have some benefit with it being straight and narrow. It may help us with patients with smaller mouth openings, such as our infants and children in particular, or patients with a floppy epiglottis. So I get in the vallicula with the MAC and I start to lift. I'm not able to lift the epiglottis up. Or patients with a very large or prominent incisor teeth. The Miller device may help us actually lift instead of displace at that point. Sometimes even the most experienced intubators may have difficulty even with a great view of the vocal cords, and so this is something that we want to discuss. Is once we get to the glottic opening, rotating that ET tube is sometimes the key. Some of the anesthesia literature suggests that the right side snag would be the most common cause of not being able to get the tube in. This is something we could rotate the tube counterclockwise to get a better orientation of the curve to where the bevel is going to follow in through the vocal cords. So with us having the new King Vision, this is a new device for us that gives us an extra tool in our toolbox. We would like for everybody to be competent in both type, the traditional and the video system, the King Vision system. And what that does is just allows our toolbox to be opened even wider. It's no different than when selecting an IV, whether it be a 22 gauge catheter versus a 16 gauge. You're going to use a little bit different technique to get those catheters to go in. It's no different with our blades, and they may suit us for what the situation we need, whether it be the patient be very anterior. The camera blade may help us, and we're going to talk about that camera blade a little bit more. One of the biggest things to remember about the King Vision is that this is not a displacement tool like the Miller and the Macintosh is. We want to take a very light grip and we want to rotate this blade into the mouth. Some of the benefits of it is the screen allows us to have a couple of different people watching that could help with that process or to confirm that that tube was in place. Using the channel blade, we'll preload that ET tube so it'll free us a hand for suction and still have the tube right there readily available. And it also may be an easier manipulation for the bougie to be inserted. We want to once again have a light grip with that. We want to prevent from that death grip, that hard grip. We want to be able to slide that in very quickly, very easy. It shouldn't be a lot of force and pressure to get that to go in. Some of the other benefits is if they have minimal head or neck movement, whether it be from trauma or kyphosis or a suspected cervical injury, this gives us a means to use something without a lot of displacement at that point. Just like anything else we have, the King Vision does have disadvantages. The channel blade can only accommodate a 6.0 ET tube up to about an 8.0 ET tube, so it's very limited with the size tubes we can use. Also, with having the channel blade, it is a lot to place into the mouth, and so infant and children may not be able to use this device on just due to the amount of room, or some even smaller adults with small mouths. This may not be an option. If the airway isn't suctioned well before, during intubation, some of the fluid can obstruct the camera's view, so that can definitely cause us some problems. As demonstrated here, the correct way to grab the King Vision is once again a little bit lower at where the division starts for the channel blade. This gives us a good position to be able to rotate the blade in, and it prevents us from using the death grip. A lot of times when we use that death grip and we're trying to muscle this in instead of technique, we'll end up getting the blade very deep, which we're going to show you some videos shortly of that, and being able to manipulate that into the airway. As discussed before, there is a channel blade option and a non-channel blade. We want to make sure that we do not use a stylet with the channel blade process, because that'll make it too rigid to slide through. But we do want to preload that channel blade with a lubricated ET tube. You can consider putting a bougie in place with that also. When using the preloaded channel blade, your right hand is pretty much free until you get ready to advance, so it gives you something to work with, whether you need to add crack pressure or you need to suction a dirty airway. The King Vision works again by gentle manipulation and rotation, not brute force. A lot of times if we are hitting too low, the endotracheal tube will snag on the cartilage there, and it will not advance at that point. If it's too high, I can't get a good look at the epiglottis coming up, and instead I'm going to be pushing the blade more down. If it snags on the side, it's very simple to correct. I can just rotate in a counterclockwise with the actual blade, just rotate it just a little bit to where I get the curve in the bevel and the right angle to get in. With the unchanneled blade of the King Vision, it does require a metal stylus to be put in to where we have a stylet in there to be able to give some rigidity. The bougie will not work with this in this case, and it cannot hold the tube shape because remember, I'm not displacing, I'm rotating this in. But the non-channel blade does give us some benefit because I can go smaller than a 6.0 tube, so if the patient's mouth can hold the larger blade of the King Vision, then I could use a smaller tube, or I could use a larger tube if I needed to at the end of the day. As we compare the King Vision to standard or traditional intubation, with the King Vision we want to enter midline and over the tongue, and as the blade slides down, we'll follow the tongue itself. In using traditional system, I'll be able to start with the right side of the patient's mouth and move toward the left somewhat area in order to displace the tongue and move it out of the way. So it's best to gradually enter the laryngopharynx and work your way to the epiglottis with the King Vision. So it's more of a rotation instead of a blunt force.
So here the Vivitrac is entered into the oral cavity. You can see some residual emesis in the oral cavity. The paramedic is placing the ET tube, but seems to be stuck at the cords and a bit off to the right. So they do a nice job of pulling it back a bit and redirecting it. And they continue to try to advance it until it goes through the cords. And that's very nice. And the movements that you see are chest compressions are being done, hence the pulsations that we see on the bottom of the screen. But despite the chest compressions and the movement of the vehicle, there's a very nice midline steady airway visible, and that's not moving quite a lot. And here the Vivitrac is reinserted to confirm the placement of the tube. So it's inserted again into the oral cavity. This time the ET tube is already in place, as you can see it on the right-hand side, and confirmation of the tube is visualized beautifully. So here they're entering the oral airway, but they're not midline. You can see that they're off to the right, and therefore the tongue is in the way here. You can see the molars there. So it's a nice attempt to take the device out, reposition in midline, and enter the oral airway. Nice view of the cords. They're small in the distance. Here you need to twist the tube counterclockwise in the channel, just like they did, so that you can enter the cords perfectly. Excellent. Very nice intubation on a very challenging, obese patient. So here the Vivitrac device is entered nicely midline and you get a good view of the cords, albeit it's a little bit too close. So you need to pull back from the airway and make the device a bit more vertical. This will prevent the tip of the ET tube from hitting the cartilage. The user also needs to twist the ET tube counterclockwise in the channel to align it with the glottic opening. So here they pull it back out, and the distance is good, but the device, I can tell, is not vertical because the cords have not come into good view here. There. That view and then subsequent insertion of the ET tube. Nice done.
So we successfully got our patient intubated. You got to see several videos over how to, some little techniques to help with the King Vision with traditional and kind of what we're looking for. So what's on the menu next? What do we need to do on the post-sedative side? How are we going to take care of those patients to keep them comfortable? So we have a couple of options with Versed and fentanyl, or fentanyl alone, or ketamine. It depends on the patient's condition. This is something we allow the paramedic to be able to make those educated decisions on what is best for the patient at that point. Everything is great. We just need to sedate them and give them pain control. Are they hypotensive? Are they having bronchospasms, low cardiac output? We have to weigh all these things as we begin to make decisions on post-sedation. So when do I need to resedate? Once I get the ET tube confirmed, I start to get everything kind of stabilized. I've got the capnography on. I've confirmed my tube placement. I've listened. I have misting in the tube. I have the tube secured. I need to start thinking about reparalyzing possibly or sedating these patients. We always want to try to stick with just sedation if at all possible, so that patient is not paralyzed when they arrive at the hospital. But sometimes that is not a factor, and sometimes we have to reparalyze those patients. Watch the signs for discomfort. So some of the things that may lead me to know that I need to sedate is I may have an increased heart rate, increase in blood pressure, unexpected capnography changes such as a Curie clef, and that's going to be where demonstrated to the right. You'll see a small dip. That's where the patient's actually trying to take a breath right there in the exhalation portion before it gets to the inhalation portion. You may see diaphoresis, tearing, or biting on the tube, or just the discomfort of the patient. For many years, we used Versed as an induction agent to initially start the PAI process, and we've determined that this is not the best drug. Some of the reasons for that is it has a longer onset time, where the etomidate has about 15 to 45 seconds. The Versed is about 60 to 90 seconds. It also has a greater risk of hypotension. However, it works very well on the post-sedation side to where we make the patient sedated to where they're comfortable. After intubation, the sedative onset does not need to be rapid at that point. And so it just is going to give us a way to improve our oxygenation, our ventilation, and let us control things. Although we got to remember one thing about Versed is it does not address the pain issues. So our dose for Versed is 0.1 milligrams per key to a max of 10 milligrams. Onset is 60 to 90 seconds, and duration is 15 to 30 minutes. As we talked about, Versed does not have any analgesic or pain management properties. A lot of times we add fentanyl to this. However, the combination of both of these drugs meets the sedation, amnesia, and pain relief all in one. Compared to morphine, fentanyl is less likely to drop blood pressure, so it's very safe. Although we remember on the Versed side, we do can have a dramatic drop in blood pressure. So it's something we have to be able to consider. Can the patient tolerate that with coronary pressure and cerebral pressure? We do have the option of fentanyl alone. This is mainly going to handle just the pain management side of this. It is going to be fentanyl is a short-acting synthetic opioid that can be used for the analgesic effect. Remember, it does not have a lot of blood pressure effect, but it works very, very well with Versed. 100 micrograms of fentanyl has about the same analgesic effect as 10 milligrams of morphine by the literature, and therefore it does very well with controlling those patients. However, if the patient's blood pressure is considered post-intubation to be low, to be hypotensive, and we're having a lot of trouble with the blood pressure, one of the other options may be ketamine for us, and we'll discuss that shortly. So what's our dose for fentanyl? 2 micrograms per kilogram to a max of 100 micrograms. The onset of this drug should be between 2 and 3 minutes, and the duration should last between 30 and 60 minutes. As we move to our second option for post-intubation care, we like to talk about ketamine. Ketamine is not only useful for dissociative induction agent, but it also has very good properties for post-intubation as well. It handles a lot of things with hypotension, so it can drive pressure a little bit. It can help with bradycardia, and it also can be beneficial during bronchospasms. With it being a beta 2, can help open up those bronchioles. Not only does it provide an anesthetic effect, but also a dissociative effect and some amnesia during this event. The 500 milligram max dose is what ketamine is, and so the dose for ketamine is 2 milligrams per kilogram slow IV push to a max of 500. The onset should be 45 to 60 seconds, and the duration should last between 10 and 20 minutes. Thank you once again for joining us. Our references are in the slides, and the extra references that we've used today are on this page. Once again, we thank you for using UMCMS for your continued education needs. And also, if you could log into your Quest-based account and please complete the quick survey of our CE process and answer the quiz to meet state requirements. Thank you and have a great day. Bye-bye.